Welcome back to the deep dive. We're here to take those really dense academic sources you need to tackle and pull out the absolute must-know insights. And if you try to get your head around the body's internal battle plan, how it responds when things go wrong, like an injury, well, this is your deep dive.
That's right.
We are slicing through the detail in Porth's essential chapter, chapter 9, inflammation, tissue repair, and wound healing.
Yeah, and this is really foundational stuff because, I mean, at its core, inflammation is the reaction of tissues that have blood vessels, vascularized tissues, to some kind of cell injury.
Okay.
It's the whole process that ideally destroys the invader or cleans up the damage, and then it sets the stage for getting things fixed. Repair.
Repair, right.
But the really critical insight here, the one that's easy to miss sometimes, is when this whole protective thing gets, well, dysregulated. Or it just goes on way too long. Then it stops being protective. It actually becomes the root cause of some major chronic diseases, things like asthma, atherosclerosis, the list goes on.
So our mission today is to walk you through that whole process, kind of step by step. And to do that, we're going to use the classic signs of acute inflammation. They're like our roadmap.
The cardinal signs.
Exactly. We're talking about those 5 signs. Rubor, that's redness. Calor, heat. Tumor, which is swelling. Dolor, pain. And functiolesa, loss of function. They literally map out the entire sequence of that immediate acute response.
Okay, so we start with the vascular phase. This is the immediate bit, almost reflexive, really.
Like when you get a cut.
Exactly. You might notice, just for a split second, the vessels clamp down. That's momentary vasoconstriction. But almost instantly, that's overwhelmed by rapid vasodilation.
So the pipes widen.
Right. Big increase in blood flow right to that spot. And that delivers the warmth, the calor, and the redness, the rubor, that you see and feel.
Okay, so more blood flow explains the heat and redness. But what about the tumor? The swelling? That can be massive sometimes. How does that happen? Does the vessel wall itself actually change?
Oh, absolutely it does. The key change is a really rapid increase in vascular permeability.
Permeability?
Yeah.
Meaning leaky.
Yeah, exactly. The endothelial cells that line those tiny vessels, they actually contract slightly and pull apart, creating little gaps between them.
Okay.
And this lets fluid, but importantly, protein-rich fluid, we call it exudate, just pour out into the surrounding tissue space.
Ah, the exudate.
Right. And because protein is leaking out, the osmotic pull inside the capillary goes down while the pull outside in the tissue goes up. And that just drags tons of water with it into the tissue.
And that fluid buildup is the tumor, the swelling, which then, I guess, presses on nerve endings.
You've got it. Causing dolor, the pain. And it physically gets in the way, restricts movement. That's your functiolesa, the loss of function.
Makes sense.
But here's the interesting part. That fluid loss, which sounds bad, actually helps.
How so?
Well, the blood left inside the vessel is now thicker, more concentrated, so it flows much more sluggishly. It stagnates. And that stagnation helps trap any infectious microbes right there. Kind of starts the walling off process almost immediately, containing the problem.
Right, contain the threat. So that walling off helps set the stage for the next phase, the cellular phase, the arrival of the cleanup crew.
Precisely. The whole goal now is to deliver defensive cells to the site. And the main ones, especially early on, are the polymorphonuclear neutrophils, PMNs.
PMNs. Okay, so how does the body get these spectralized white blood cells out of that now sluggish blood flow and into the tissue where the problem is?
It's quite a remarkable process, like cellular traffic management.
Okay.
So as the blood flow slows down, the PMNs drift from the center of the vessel towards the edges. That's margination.
Moving to the margins. Got it.
Then they start to tumble along and actually stick to the inside lining of the vessel, the endothelium. That's adhesion.
Good.
And the sticking isn't random. It's mediated by specific molecules like docking proteins on both the PMN and the vessel wall. Things called selectins and integrins.
Okay, so they slow down, move to the edge, stick.
Right.
Then they have to get out, right?
Right. That's transmigration, sometimes called diapedesis. They literally actively squeeze themselves through those gaps that opened up between the endothelial cells.
Wow.
And once they're out in the tissue, they don't just wander around hoping to bump into trouble. They follow a chemical trail. It's called chemotaxis.
A chemical breadcrumb trail. What makes up that trail? What are these chemical signals?
They're guided by a gradient. They move towards the highest concentration of these chemoattractants. These include specific signaling molecules called chemokines, but also fragments from the complement system, specifically C3a, and C5a.
Complement. We'll come back to that.
Yeah, but these act like homing beacons, basically directing the phagocytes, the eating cells, right to the source of the injury or the microbes.
Okay, so they arrive. Now it's time for phagocytosis, the eating and the killing. But how do they know what to eat? How do they tell friend from foe?
That's a really important question. Most microbes, they need to be flagged first, made more obvious. Yeah, it's a process called opsonization. The microbe gets coated, usually with antibodies or, again, complement factors like C3b.
C3b.
Think of C3b like putting a bright "Eat Me" sticker on the bacterium. The phagocyte has receptors that instantly recognize that sticker.
Gotcha. Makes it easy to spot.
Makes it easy. So the phagocyte engulfs the opsonized microbe, pulls it inside into a little membrane bubble. That's the phagosome.
Okay.
Then that phagosome fuses or merges with another internal pouch called a lysosome, which is packed full of digestive enzymes.
Right, the digestive part.
Exactly. And that combined structure, the phagolysosome, that's the killing chamber. That's where the microbe gets destroyed, using both those enzymes and also powerful oxygen-free radicals.
Okay, so the cells are the soldiers doing the work, but there's got to be a communication system, right? Telling them what to do, coordinating everything. That's the inflammatory mediators.
Absolutely. They're the signals, the control tower. And we can kind of group them by what they do. First off, you've got the ones that act super fast, often because they're preformed and stored, ready to go, like histamine.
Histamine, I know the one from allergies.
Exactly. It's stored in mast cells right there in the tissue. When they degranulate, histamine is released instantly. And its main job is causing that immediate but quite short-lived increase in vascular permeability.
The leakiness we talked about.
Leakiness, yeah. It binds to H1 receptors on the vessel walls. And that's why, you take an H1 antagonist and antihistamine to block that rapid response in things like hay fever.
Makes sense. Okay, what's next? The arachidonic acid metabolites. Sounds complex.
It is a bit complex, but it's incredibly important because this pathway is where many of our anti-inflammatory drugs actually work. So arachidonic acid is a fatty acid in cell membranes. When there's injury, it gets metabolized down two main paths. First, there's the cyclooxygenase pathway, or COX pathway. Right. This generates prostaglandins and thromboxane. These are involved in lots of things, including promoting inflammation, fever, and pain signaling.
Okay. And the second path?
The second is the lipoxygenase pathway. This one generates leukotrienes. And one group of these used to be called the slow-reacting substance of anaphylaxis, SRSA.
SRSA. Why slow-reacting?
Because unlike histamine's quick hit, these leukotrienes cause a much slower but more sustained contraction of smooth muscle. And the key insight here is their effect on the bronchioles.
Asthma.
Exactly. They are incredibly potent at constricting the airways, making them a central player in bronchial asthma.
So you mentioned drugs targeting these pathways. How do things like aspirin or ibuprofen fit in?
Right. So aspirin and other NSAIDs, non-steroidal anti-inflammatory drugs, they work primarily by blocking that first pathway, the cyclooxygenase pathway.
They block COX.
They inhibit or inactivate the COX enzymes, which cuts off the production of those inflammatory prostaglandins. That's how they reduce inflammation, pain, and fever.
Got it. Okay, moving on to plasma proteins. There are three systems involved here: clotting, complement, and kinin.
Yeah, and they're all interconnected. The clotting system obviously forms clots to stop bleeding and trap microbes. The complement system, which we've touched on with C3a and C3b.
Right, the opsonization and chemotaxis?
Yes. It's like an amplification cascade. It gets activated and dramatically boosts inflammation, increases permeability, enhances phagocytosis. And then there's the kinin system. Its main product is bradykinin.
Bradykinin, what does that do?
Similar to histamine, in some ways it increases vascular permeability, but importantly, it's also a very potent pain-inducing molecule, causes dolor.
Contributes to the pain. Okay, and then you mentioned master switches, connecting local injury to the whole body, cytokines TNF-α and IL-1.
Yes, tumor necrosis factor alpha and interleukin-1. These are arguably the central orchestrators. They're released mainly by activated macrophages.
And what's their job?
Kind of twofold. Locally, they signal the endothelial cells, the vessel lining, to express those adhesion molecules we talked about, the selectins and integrins needed for the white blood cells to stick.
Okay, facilitating the cellular phase.
Exactly. But they also have major systemic effects. They're responsible for coordinating the body's bigger whole system protective response, like fever.
Okay, let's talk about the local manifestations. You mentioned exudate earlier. Does the type of exudate tell us anything?
It definitely can. It gives clues about the injury or infection. If it's thin and watery, mostly plasma, we call it serous exudate. Think of a blister.
Okay.
If it's reddish, that means blood vessels have been badly damaged, letting red blood cells escape. That's hemorrhagic.
Right.
If it's thick and sticky, almost like glue, that's fibrinous exudate. It means lots of fibrinogen has leaked out, which can form clots.
Fibrinogen from the clotting system.
Exactly. But the one most people recognize is pus. That thick, yellowish or greenish discharge, that's purulent or suppurative exudate.
Pus, what's in it?
It's basically dead and dying neutrophils, tissue debris, proteins, and often the offending microbes themselves. It's the battlefield wreckage.
And that leads us straight to a classic clinical example.
Yeah.
The abscess, that pocket of pus.
An abscess is a localized area of inflammation filled with purulent exudate. And you often hear that antibiotics alone might not clear it up.
Why is that?
Well, the body, in its effort to contain the infection, walls off the abscess with fibroblasts and collagen. It forms a capsule around it.
Okay.
That capsule, while good for containment, makes it really hard for antibiotics circulating in the blood to penetrate into the core of the abscess in high enough concentrations to kill all the bacteria.
Ah, so the drugs can't get in properly.
Pretty much. That's why surgical incision and drainage IND is often necessary. You physically have to open it up and let the pus out, remove the source.
Got it. Okay, so that's acute inflammation. What happens if it doesn't resolve, if it drags on?
Yeah.
That's chronic inflammation.
That's chronic inflammation. And the key difference is the type of cells involved. Acute is dominated by neutrophils, those PMNs. Right.
Chronic inflammation sees a shift. Now, the main players are mononuclear cells, mostly macrophages and lymphocytes.
Different cells taking over.
Different cells, and crucially, you also get active proliferation of fibroblasts. They start laying down collagen, and this significantly increases the risk of permanent scarring and tissue deformity.
Scarring. Okay. And what if the body encounters something it just can't get rid of, like a splinter it can't digest?
Ah, that leads to a very specific type of chronic inflammation called granulomatous inflammation. It forms a structure called a granuloma.
A granuloma.
Yeah, it's the body's way of walling off indigestible foreign material. Macrophages undergo a transformation. They become larger, sort of flattened cells called epithelioid cells.
Epithelioid, like epithelial cells.
Kind of look like them, hence the name. And these epithelioid cells can fuse together to form really large, multinucleated giant cells.
Giant cells, wow. And together, these cells form a tight cluster, a granuloma, literally building a wall around things like silica dust, asbestos fibers, surgical sutures, or even hard-to-kill microbes like the bacteria that cause tuberculosis. It's containment when destruction fails.
Fascinating. Okay, let's zoom out from the local site. What about the systemic manifestations, the whole body response? You mentioned fever.
Right, the acute phase response. That's the term for the systemic effects. Fever is a big one. Those cytokines we mentioned, IL-1 and TNF-α, act on the hypothalamus in the brain, basically resetting the body's thermostat upwards.
Making you feel hot.
Yep. And along with fever, you usually feel generally unwell, that malaise. Internally, the liver gets signaled to ramp up production of certain proteins called acute-phase proteins.
Okay, like what?
Key ones are fibrinogen, which we already mentioned in clotting and fibrinous exudate, and C-reactive protein, or CRP.
PRP, I've heard of that in blood tests.
You probably have. Measuring CRP levels is common, and what's become really important clinically is high-sensitivity CRP, or HSCRP. Yeah. Elevated HSCRP is now used as a marker for increased risk of cardiovascular events like heart attacks.
Why? What's the connection?
Because it reflects low-grade chronic systemic inflammation, which is often linked to the inflammation happening inside atherosclerotic plaques in blood vessels. Unstable plaques are dangerous.
Wow, okay, so CRP links inflammation to heart disease risk. What else happens systemically?
We also typically see leukocytosis,
Meaning?
for just an increase in the number of circulating white blood cells, especially neutrophils. The bone marrow ramps up production to fight the infection.
Okay.
And sometimes, particularly if the infection is really severe, the demand for neutrophils is so high that the bone marrow pushes out immature forms, called bands, into the circulation. Seeing lots of bands, a left shift, tells you the body is under serious stress.
A left shift, okay.
Yeah.
And what's the worst case scenario for this systemic response?
The worst case is when it spirals completely out of control. If there's a massive, overwhelming infection or injury, you can get a huge, unregulated release of inflammatory cytokines throughout the body.
Like a cytokine storm.
Exactly. That leads to a devastating condition called sepsis, or the systemic inflammatory response syndrome,
Yeah.
SIRS, widespread vasodilation, leaky vessels everywhere. It can rapidly lead to circulatory collapse and shock, life-threatening.
All right, so assuming the inflammation does its job, clears the debris, controls the infection, then we move into tissue repair, getting things back to normal or as close as possible.
Right. And the type of repair that's possible really hinges on the tissue regeneration capacity of the cells that were damaged.
Meaning, can the cells actually divide and replace themselves?
Exactly. The body basically categorizes cells into 3 groups based on this ability. First, you have labile cells.
Labial.
These cells are dividing constantly throughout life to replace cells that are normally lost. Think of the surface epithelia, your skin, the lining of your gut, your mouth, always turning over.
Okay, so they regenerate easily.
Very easily. Then you have stable cells. These cells normally stop dividing once growth ceases. They're kind of in a resting state, G0.
Resting, but not dead.
Right. But if they get injured, they can be stimulated to re-enter the cell cycle and divide and regenerate. Good examples are liver cells, kidney tubule cells, smooth muscle cells.
So the liver can regenerate, to some extent.
To a remarkable extent, yes, if the underlying framework is intact. But then we have the third group, permanent or fixed cells.
Permanent, that sounds permanent.
It is. These cells are considered terminally differentiated. They left the cell cycle way back in development and cannot undergo mitotic division in postnatal life.
What kind of cells are these?
The big ones are nerve cells, neurons in your brain, and spinal cord skeletal muscle cells, and critically, cardiac muscle cells, heart muscle.
And the consequence here is huge, right? If these permanent cells are destroyed.
They're gone for good. The body cannot replace them with identical functional cells. The only option is to fill a gap with non-functional connective tissue, fibrous scar tissue.
So you lose function permanently.
You lose function. The organ's capacity is permanently diminished. That's a crucial concept.
Definitely. Okay, so let's assume we can heal. The general process depends on how much tissue is lost. That determines the healing intention.
That's right. We talk about 2 main types. Primary intention healing happens when there's minimal tissue loss and the wound edges are closely approximated. Think of a clean surgical incision that's been sutured shut.
Neat and tidy.
Neat and tidy. It heals relatively quickly, predictably, through the phases, and usually leaves just a fine linear scar.
Okay. And the other type?
That's secondary intention. This occurs when there's significant tissue loss. A large scrape, a burn, a pressure ulcer, any wound left open.
Much bigger gap to fill.
Much bigger gap. So it takes substantially more time, requires more tissue regeneration or filling in, it heals from the bottom up, and it inevitably results in a larger, often more irregular scar. Contraction is also a much bigger feature.
Okay, primary and secondary intention. But regardless of intention, healing seems to follow distinct phases, starting, again, with inflammation.
Yes, the inflammatory phase kicks things off for healing, too. It starts immediately with hemostasis stopping the bleeding, forming a clot. That clot provides a temporary scaffold.
And the cleanup crew arrives.
The cleanup crew arrives. Neutrophils, PMNs, are there first, within hours, cleaning up bacteria and debris. But then, usually by day 2 or 3, the macrophages become the dominant cell type.
Macrophages again. Why are they so crucial here?
They are absolutely essential. They continue the cleanup, phagocytosing debris and dead cells. But critically, they release a whole cocktail of growth factors. These are the signals that initiate and drive the next phase.
Which is the proliferative phase. Proliferation meaning growth.
Exactly. This phase is all about building new tissue to fill the wound space. And the star player here is the fibroblasts.
The fibroblast, what does it do?
Fibroblasts are connective tissue cells that migrate into the wound and start synthesizing and depositing collagen and other components of the extracellular matrix, or ECM. They basically build the new scaffolding.
Laying down the foundation.
Laying down the foundation. At the same time, we see angiogenesis,
New blood vessels.
formation of new capillaries. These sprout from existing vessels and grow into the wound bed, bringing oxygen and nutrients needed for repair. This combination of fibroblasts, collagen, and new capillaries creates a soft, pinkish, granular-looking tissue. That's granulation tissue.
Granulation tissue. You see that in open wounds.
We do. It's fragile but essential. And while this is happening underneath, on the surface, epithelial cells from the wound edges start migrating across the granulation tissue base to cover the wound. That's epithelialization, forming the new skin or mucosal surface.
Okay, so inflammation cleans up, proliferation builds the structure. What's the final phase?
The final and often longest phase is the remodeling or maturation phase.
Remodeling, like renovating a house.
Kind of, yeah. It typically starts around 3 weeks after injury, but it can continue for months, even years. It involves ongoing work on that collagen framework that was laid down.
What kind of work?
It's a dynamic process. Fibroblasts continue to synthesize new collagen, but at the same time, enzymes called collagenases are actively breaking down some of the previously formed collagen.
Building up and breaking down simultaneously.
Exactly. This continuous synthesis and lysis, this remodeling, gradually reorganizes the collagen fibers, makes them stronger, more aligned, and increases the tensile strength of the scar tissue. The scar also tends to contract or shrink over time during this phase.
So the scar gets stronger but smaller.
Ideally, yes. But sometimes this remodeling process goes wrong. If there's excessive production of collagen way beyond what's needed, you can get hypertrophic scars or, even more dramatically, keloids.
Keloids, those raised, overgrown scars.
Right. That's an abnormality of this remodeling phase. Too much collagen deposition.
Okay, so that's the ideal pathway for healing. But we know it doesn't always go smoothly. Things can interfere. What are some key factors that can impair or slow down wound healing, starting with, say, malnutrition?
Oh, absolutely critical. Healing is an incredibly energy-demanding, metabolically active process. You need fuel.
Calories.
Calories, yes, but also specific building blocks. Adequate protein intake is essential for cell proliferation and collagen synthesis.
Makes sense. What about vitamins?
Certain vitamins are non-negotiable. Vitamin C, ascorbic acid, is absolutely required for fibroblasts to synthesize strong, stable collagen. Without enough vitamin C, you get scurvy wounds break down, stars are weak.
Wow. Okay.
Any others? Vitamin A is important for epithelialization, that surface covering process, and also supports angiogenesis. And minerals like zinc act as essential cofactors for many enzymes involved in cell division and protein synthesis. So poor nutrition is a major barrier.
Okay. What about blood supply?
Hugely important. Impaired blood flow and oxygen delivery or hypoxia is a major roadblock to healing.
Why oxygen specifically?
Several reasons. Fibroblasts need oxygen as a direct reactant to synthesize collagen properly. Without enough oxygen, they just can't build strong tissue. Also, remember those phagocytes, the neutrophils? Their ability to effectively kill bacteria using those oxygen-free radicals. The respiratory burst is severely hampered without adequate oxygen.
So poor oxygen delivery means weaker tissue and higher infection risk.
Exactly. Ischemic tissue with poor blood flow, heals slowly and gets infected easily. Think about diabetic foot ulcers, for example.
Right, which brings us to underlying diseases.
Yeah.
You mentioned diabetes mellitus. How does that impair healing?
Diabetes is a major culprit for multiple reasons. High blood glucose levels directly impair the function of neutrophils. They don't follow the chemical trails as well, chemotaxis is poor, and their ability to phagocytose is reduced.
So the initial inflammatory response is weaker.
It's less effective. Plus, many diabetics develop small vessel disease, which compromises that crucial blood flow and oxygen delivery we just talked about. It's a double whammy.
Okay. Any other conditions or maybe medications?
Well, anything that suppresses the immune or inflammatory response can interfere. High doses of corticosteroid drugs, for example, are potent anti-inflammatories.
Which can be good sometimes.
Can be good for treating inflammatory diseases, yes.
Mm.
But if someone is taking them and gets injured, it can suppress that necessary initial inflammatory phase of wound healing, delaying the whole process and increasing infection risk.
I see. And finally, what about just having an infection in the wound or a foreign body?
Both are major impediments. An active infection keeps the inflammatory phase going indefinitely. The neutrophils keep coming, releasing enzymes that can actually damage surrounding healthy tissue, preventing the transition to the proliferative phase.
The healing stalls.
Healing stalls. And foreign bodies, things like dirt, glass, wood splinters, even surgical sutures left in too long, act as a persistent irritant. They invite bacterial contamination and provide a surface, a nidus, for infection to take hold, again, prolonging inflammation and delaying closure.
That's why they remove stitches relatively quickly.
Exactly. As soon as the wound edges are strong enough to hold together on their own, you want those sutures out to minimize the foreign body reaction. Hashtag tag outro. So if we try to synthesize this whole chapter, pull it all together. The main takeaway is that the ultimate outcome of any injury really depends on this intricate, precise balance. The balance between inflammation, that initial necessary phase of cleanup and destruction, and the subsequent repair process, either regeneration or scarring.
Destruction versus construction, in a way.
Yeah, you could think of it that way. And that final outcome, whether you get perfect restoration or just a patch job with a scar, is fundamentally dictated by the type of cells involved. their capacity to regenerate, labile, stable, or those critical permanent cells.
Right. And that framework, thinking about permanent cells, it leads to a pretty sobering final thought, doesn't it? Think about the ultimate price of repair after, say, a myocardial infarction, a heart attack. Part of the heart muscle dies.
Right, permanent cells.
Permanent cells. So the inflammatory response comes in, clears away the dead tissue. The wound heals by forming a scar. It is successful healing in a biological sense.
The defect is closed.
The defect is closed. But because cardiac muscle can't regenerate, it's replaced by non-functional fibrous scar tissue. So the patient recovers, the heart is healed, but its overall ability to pump, its contractile function, is permanently reduced.
Successful healing guarantees functional loss.
Exactly. It's a powerful reminder that even when the body's repair mechanisms work as designed, there can be significant long-term consequences based on the tissue involved.
Biology has its limits indeed. Well, thank you for allowing us to conduct this deep dive into your source material today. We really hope this roadmap helps you master these crucial concepts of inflammation and repair from Porth.
Absolutely. Thanks for joining us on the deep dive. Until next time, keep digging into the details.